unmuted, unmute करके
Dr.
kindly
Avasthi.
you can introduce the speaker.
Am I okay now?
Yes sir, yes,
Yeah.
yes sir.
Oh great, that's wonderful. सबसे पहले तो मैंने मेरे बड़े क्लोज फ्रेंड तो है ही है, साथ में छोटा भाई भी है, डॉक्टर गौतम साहब को देखा है स्क्रीन पे. नमस्कार. Okay, so and I'm so delighted that my very good friends are around, and so many young people are there on the panel and who are a part of this wonderful program. I believe, I wish if Dr. O.P. Singh had introduced everybody, I will request him to introduce the speaker. I will just give a few introductory remarks. I think I need to congratulate people who are associated with this initiative. I'm aware of Dr. Tufan Pati, Dr. Alim Siddiqui, Dr. Amritpal Joshi, and there must be many more who are associated with this program, and they need our deepest appreciation. And I'm really enthralled that they have picked up a topic which is the need of the hour. This is a favorite topic with me, and I'm sure my very dear friend Dr. Vidyadhar Bhatve will agree with this as a past president, how much we have been conscious of the fact that in IPS, we should have a very strong forum for psychotherapy. So it's great that you have thought of this particular topic, and we have a very illustrious speaker. I will not stand too much between the speaker and the program. So I request now Dr. Om Prakash Singh to introduce our honorable speaker for this evening's program. Dr. Om Prakash Singh.
Sir, good evening. First, it is my pleasure to be here with Dr. Tufan Pati organizing this, and my dear brothers and charismatic Alim and Amrit, thinking of this program by all three. This is something wonderful. And as you have said, sir, this is, of course, capacity building for psychiatrists to do psychotherapy in clinics and to understand the basic things. And when coming to NSSI, it is something which I was interested. I became interested 1 year back and wrote an editorial also, because 20% of the people, adolescents, are having this kind of thing, which must be distinguished from what we used to be read as DSH. So this is something, and this program is wonderful program. This is the 4th edition, and with high appreciation and attendance. And I must congratulate again the organizers, Dr. Tufan Pati, Dr. Amrit and Dr. Alim, for thinking and executing this program. And now it is my pleasant duty to introduce the speaker. Slide please, if it is available.
One.
So Dr. Purnima Bhola is additional professor of clinical psychology in NIMHANS, and she is one person who has been working in NSSI field. So more than 6 projects in, she has more than 9 research projects in the field of non-suicidal self-injury, and she is heading the SAFE initiative, and she has co-edited a book which examines ethical challenges in which has been published by Springer, and also she is bringing a new book on psychotherapy, a reflective part of it. Next. So this is wonderful. I think that she is the most qualified person to talk about NSSI, and I think all of attending people, a lot of young people are there, will benefit to handle this patient and have confidence in this. So Dr. Purnima Bhola, please.
Just one moment, please. Just one moment, I'll share the screen.
I thought for a while that Purnima has bolted out of this table like a horse, you know. So I missed my beat when she said just a minute and she was no more on the screen. I thought she's gone, but there she is again. So
Just
good.
one moment. I'm trying to share
In
the
2
screen. There
moments, no
seems to be
problem.
some
We are very generous people.
technical difficulty. Just
You
give me
can
a
take even 3 moments. Amriji, ठीक है?
minute. Okay. All right.
आप हैं सर, हम लोग क्या है? You are
अलीम
the
साहब ने तो इजाजत दे दी है. Good. I saw Vivek. That was wonderful seeing him after a long time.
So this is a pleasure, sir, to be with you in this chair. And again, we will have your criticism and comment. So this will be
I
a
am
very
honored,
good
sir.
interview.
I am
Acha,
honored.
Exactly,
Purnima,
if you are
sir.
having any problem,
Nice to
can
see
you
you
mail
also.
to
Knowledge
the...
and fun.
Hi, Gautam. Welcome.
Hello, sir.
And go
Hello,
with
sir.
Gautam and a lot of other people are there.
Acha,
So
Purnima,
we
if you are
did-
having any problem, you mail your presentation to me. I shall send it to the
अलीम साहब,
support staff.
Yes,
Very-
sir.
I will
ये
just do that.
गौतम जी
Okay, okay.
ने वेट
हेलो
पूरा कर
सर,
लिया.
हेलो सर. सर, आपको बहुत अच्छा लग रहा है देखने में. Long time. अभी तो
Joy,
there is
such
no
a joy.
conference, in-person
Sir,
conference.
we would have been happy to spend evening otherwise, but still
Yeah.
it's such a pleasure.
sir.
Great.
There is a chat for you.
भाई अजीत भाई कैसे हैं?
Namaste,
sir.
namaste, Bhai Sahab.
I've seen mobile.
Ah, that's right.
Yeah.
And with our so efficient moderators, we have a relaxed evening.
Ah, very much so. Absolutely.
We need the valuable feedbacks from the chairpersons also.
Of course, sir. We'll do our duty. With Dr.
Because-
O.P. Singh around, there is no problem.
Sir, you are there. I will just bask in your light.
That's
And
kind
this
of
is-
you, sir. You're always very generous.
This topic is very much timely.
Yeah. That's
So
good.
So I
Next time also
request
we have
Amin-
a corollary
could
to this.
I,
Then,
could I just check? Do I have permission to share?
yeah.
Is that the problem?
Pavan,
Pavan,
Yes, it is open. Anybody can share. I mean,
madam, you can share.
Ah,
Madam, you can share.
permission
Okay,
to share is there.
I'm just going to mail the slide because
You
for
just
some
have
reason.
to change your setting in the Mac to allow them to allow Zoom to share, because sometimes that becomes a problem.
Okay,
If it's a
Madam
Mac,
is
just-
mailing the.
enable
I have
language.
just mailed it because at this point it's a little difficult for me to figure out the setting.
Okay.
you have mailed it to me.
Yes, I mailed it.
CC हुआ है कि ऐसे ही हुआ है?
मेल तो आया नहीं है अभी तक.
आ जाएगा, आ जाएगा. अलीम बोलो. एक सेकंड.
विवेक जी, नमस्कार.
yeah, it is now working.
I
Yes,
think we are online now.
All right, let me just start it then.
Purnima ma'am, we can see your screen now.
Okay, great.
Okay, so there. Nice.
Okay, excellent. Sorry for the glitch at the end. I don't know why that
No,
happened.
There is more time for you. Doesn't matter. Extra
Okay.
time if you need.
All right, so I'm going to talk today. Thank you so much for giving me this opportunity. This is a real pet topic for me, both in terms of clinical work and, of course, research and training as well. So, of course, as you all know, it's become quite a problem among young people, not just teenagers, but even emerging adults in colleges. And these are a range of behaviors in which an individual intentionally inflicts some harm to their body, where there's damage to the body tissue. And of course, this is not activities like tattooing or self-injurious acts that are part of religious or cultural practices. And at least consciously, these individuals don't express any suicidal intent. Now, how did my interest in this really begin? I think right from the start, I think from the time that I joined NIMHANS, somehow I began seeing a lot of patients with borderline personality disorder. Um, and of course, that is trial by fire, right? Because as you enter into it, they exhibit a lot of difficult behaviors, and self-harming behaviors is one of them. So when I began, I really thought that this is something that is a behavior very closely connected with borderline personality disorder. But as I went on in my practice, I saw more and more very young people engaging in this behavior. I actually remember a young teenager. She was about 14, and she one day she opened up her guitar case and showed me various implements, blades, other sharp objects, compass, all of these things which she had kept hidden to harm herself, on her arms, on her thighs. And I was really taken aback. And then I began asking my clients more and more. And as I asked them, I realized there are many, many young people who are engaging this behavior. So I think that's really when it began. And it's a puzzling, it's an emotionally difficult behavior even for a clinician, because it's you don't know why they're doing it. Sometimes you feel quite helpless, and the process of getting them to stop engaging in this behavior is really quite a difficult one. So of course it's a challenge, but perhaps these are the challenges that as clinicians we feel extra drawn towards, and we want to really do something in the area. So today, when I'm going to talk to you about it, I'm going to talk to you about findings that are very much based in India, which are part of the various research projects that I have conducted or mentored my students in. And so this is not really just drawn from Western literature. So we can't say it doesn't happen in India. Okay. So these are some of the key questions we'll quickly go through. So in India, how many people are actually engaging in non-suicidal self-injury? We already have some idea from Dr. Singh's opening remarks. And what are these characteristics? Who are these people who injure? What do they do? When do they do it? Where do they do it? And perhaps most puzzling for all of us is, why do they engage in this behavior? And I'll take you all through the process of assessment of all these aspects. How do we conduct a comprehensive and meaningful assessment? All the characteristics of NSSI, the risk factors and vulnerabilities, some sort of understanding of the very complex relationship between NSSI and suicide, and what does it mean for us as clinicians. Um, I think another aspect is that sometimes we may dismiss self-injury because we think so many people are doing it. So the idea really is to see that, are all self-injurers alike, or are there some subgroups of them who are more vulnerable, need more attention from us, and need more intensive kind of intervention. So that's something also we'll examine. And finally, after doing a comprehensive assessment, what are the different intervention approaches and stances that we can take for NSSI? And I will say that really the literature is quite limited when it comes to intervention. It's a behavior that is only now being seen separately or disentangled from the whole idea of DSH or suicide, and it's sort of being looked at on its own. And in the recent DSM, it is listed as a condition for further research and study. So I think we are on really, at the cutting edge, so to speak, of work in this area, and is something that all of us are encountering very, very frequently. So I'm hoping that, after the presentation, there's going to be a lot of opportunity for interaction and for other people to share their experiences and perspectives as well. Okay. So, like I said, we're going to have it very much anchored in India itself. And though a lot of research has been done, but I'm going to share some of the findings from fairly recent research of one of my PhD students who did a very large scale kind of study with a very good sampling design. So I think we are quite confident about the results, at least in an urban setting. So you find that, as Dr. Singh earlier said, around 20% report having engaged in this behavior at least once in the past 1 year. So that's a really large number of young people. This research was done on people from 18 to 24. And sometimes we would find another ICMR funded study that had done earlier, since it included adolescents, the rates were actually higher. So that's quite alarming, this sort of figure. And what's also more important perhaps is that in the clinic, we are really seeing the tip of the iceberg. Most of these people who are injuring are sort of hidden in the community, and they often, because it's a hidden behavior as well, they work hard to conceal it. They don't disclose about this very often. So I think many vulnerable people just slip out from under the net, and we don't really get a chance to engage with them. So as I said, high prevalence of NSSI in India. Internationally, I'm talking about, like, a meta-analytical review, which has done a pool prevalence. You can see slightly lower rates, but of course there's a wide range across studies in international literature. There are studies that have reported even 40%, depending on what kind of methodology they use, what kind of sample they had, and how they actually measured and defined NSSI. But I think that we shouldn't spend too much time, really looking at this percentage. I think we need to move beyond just presence or absence and really consider things like, what is the frequency? How often is the person injuring? What are the range of methods? So the one that we are most familiar with is cutting. But actually there's cutting, there's burning, there's hitting self, there's all kinds of other ways of injuring the skin. And these are all things to be really looked at. What is the number and type of methods? Some methods are considered more severe, let's say like cutting, and some methods like hitting yourself are relatively considered minor in terms of the extent of injury that one may typically expect. So I think this is one direction the field, and this is something that should guide our assessments as well. Okay. So I'm going to talk a little bit about assessment, because I think in this sort of domain, I think back on when I first started, working with young people who injure. I would just accept what they said in the beginning. So, they would say, I cut myself last week, this is what I did. And I would go into it in detail, but I think I wouldn't really do a very in-depth assessment. And over time, I think I've realized that that is the key. If we want to do an effective intervention, spending the time to do an individualized assessment, because no one self-injurer is really like the other, even in terms of the way that they injure. And so these are things that we need to really look at. So my first message is to spend time doing a comprehensive assessment of the self-injuring behavior itself, to go beyond what the person tells you right at the outset. So let's look at what some of the research is telling us about these characteristics. So we get an idea of what do we really then need to assess. Okay. So who does it? I think in the literature also it's pretty mixed. In some of the recent work that we've done, there's a slightly higher prevalence in females when compared to males. So in the recent study done by one of my PhD students, we found that females were about 12% and males were nearing 10%. So not a huge gap, but definitely a slight difference. In previous research, I have also not found significant gender differences, because it really seems to depend on, are you, sampling young people, what kind of type of NSSI methods are you looking at, and depending on the way that you use the lens, there seem to be a lot of differences. But the key message from here is that we might be more alert as clinicians to ask about this behavior, or to even imagine that somebody might be self-injuring when it's a girl or a woman. However, research is really telling us that we would be doing a disservice if we didn't turn our gaze towards the boys and men who are also engaging in this behavior. So from the clinical point of view, this is something we have to be open to the idea that both genders are likely to injure. And so we need to ask, whenever we see that this might be a possibility, we need to keep that thing open. Having said that, I think research is consistently showing us that there's some sort of difference in the types of or ways in which men and women or girls and boys injure. Among girls, cutting seems to be one of the more preferred or prevalent method. This seems to meet some needs or seems to be a way of expressing their distress or difficulties. And of course, we have a range of behaviors: carving, cutting, scratching, burning, ripping or pulling of skin or hair. And then we find that among boys and men, hitting self is a little bit more prevalent behavior, and there is a gender difference there. And of course, you would see quite clearly that the slightly more severe manifestations of self-injury are being engaged in more often by females, and the relatively minor ones by males. Another lesson I think I learned is that since they're typically engaging in multiple methods, the first one you hear of is not likely to be the only one. And it is through experience with cases that I've learned that over time they will reveal other methods. So it's a good idea right at the outset. We know the range of different self-injuring methods there are, to ask whether they, last week you may have sort of cut yourself in this way, but other times that you've tried to hurt or harm yourself in any other way. So I think that kind of question is important. And then to ask them which one they do more often, which one they do less. Is there some kind of connection with contexts or situations where they engage in one or the other? So really doing a sort of in-depth behavioral sort of analysis of their self-injuring behaviors. Another aspect that we see is that for most people, it's a fairly impulsive behavior. So when you ask them, how much time did you think about this before you actually cut yourself? The time period is relatively short, often just minutes. And though there will be few people who report a lot of planning and preparation, but that seems to be more typical of, other behaviors and not really NSSI. The characteristic thing is that it tends to be fairly impulsive in an emotionally charged situation. It's usually one of their go-to coping methods in difficulties, and so they engage in it quite swiftly. So what that means is we don't have much time. You're not likely to have your patient come and tell you today that, I've been thinking about this for some time. So you don't have place to intervene like that. It's something that happens in the moment, and that's something we need to keep in mind while planning our interventions. Where do they usually do it? Hands, wrists, stomach, thighs. And, I remember one of my teenage clients telling me that earlier I used to do it on my forearm, but then people started noticing. So I started doing it in places where it's not visible. So I can have the same impact, but others don't get to know. Of course, like all other types of self-injury, if somebody is doing something like injuring their face, that's usually a very high risk kind of thing that we need to be very alert to. And that usually is often associated with a higher risk for suicidal intent later, and at least in some of the research that is coming out. Definitely, I was surprised when I first began working in this area that it begins quite early. So when I would ask even my clients with borderline personality disorder, let's say I'm seeing the person when they're 20, 22, and when I would ask, they would say, oh, I started when I was 13, or, and this is consistent even in the Indian research we've done. 14, 15 is kind of like the mean age at which you see this behavior beginning the first time. And of course, it goes up and down. Sometimes people can engage in it consistently for a long period of time, but it can also stop for a while and restart. And more, we are also seeing young adults who are starting, or emerging adults in college, they're starting for the first time. So again, why we would need to assess this is because typically people who started earlier tend to have more high risk profiles. So which is why this information is important, to check with them, when did you really first start harming yourself in this way. So it's a little bit of an alert for us that this person might be in a more high risk profile that I need to maybe assess some other things as well. So these are all sort of some of the red flags or indicators for us. Okay. Question of why is perhaps a really difficult sort of question, because it's tough for us to understand why someone would be wanting to hurt or harm themselves in this manner, and which is why young people, they have typically faced very difficult reactions when, let's say, teachers or parents or even peers have gotten to know about this. They usually face very negative kind of responses or reactions from people, like either shock or anger or sort of rejection, and this is usually part of their stories when they share with you. Okay? So why do people do this? I think most prominently, I think in the literature, there will be mention of difficulty in managing emotions in different ways. And so it serves to regulate your affect. So I think this is easy to understand, that if someone is very emotionally charged, they are confused about what to do, they will talk about, let's say, I cut myself and I felt a sense of release. I felt some sort of relief. So that's one way that, emotions are regulated. But the other way is slightly different. When someone says, I was feeling numb, I was not feeling anything, I was feeling almost dissociated. So when I cut myself, I could feel something. So the intrapersonal function is to sort of either reduce emotion or to bring about or increase a connection with an emotion. So it works in both directions and differently for different people. And perhaps little less focused on, at least in research, especially in Western literature, they haven't focused as much on interpersonal functions, which is, I engage in this behavior because I want someone to stop doing something, or I want someone to change their behavior, or attend to me in some way. So this could be with the parents, or it could be with peers, or it could be with anyone in an intimate relationship. So the reasons for engaging in this behavior, or what function it serves you, is it serves you some interpersonal function. And I want to emphasize this a little bit, because while of course it's quite true that affect regulation is a very prominent aspect related to NSSI, we have to spend time understanding the relational context in which it happens, particularly because we are learning more and more that this has been ignored in the literature, and there are some suggestions that interpersonal functions or interpersonal motives may be more common in non-Western cultural contexts like India, where we are very much anchored in our relationships. We have a particular collectivistic view, and there is a lot of closeness and proximity with others. So maybe we need to spend a little more time understanding the relational context in which this happens. So again, this becomes a critical part of our assessment. So I'm going to share with you, because we've done a lot of different types of research, some of which are quite quantitative, which ask people to list the reasons why they self-injure on some particular questionnaires or profiles. And then some are more narrative and qualitative perspectives. So I've just shared some comments from people saying that self-injuring youth, that before this I was feeling numb, but the self-injury, made me feel connected again. The relationship with pain is also quite interesting. This person, I remember, was a young teenage girl. She says, I think of pain in the biology textbook kind of way. It's sort of distant. It's like I don't feel it anymore. And very often people will say the physical pain is better than the emotional pain. So it's a more meaningful act for me to do. This other statement is quite remarkable. After self-harm, I can focus, I feel powerful, my body, my rules. So you can see it's a way of the person exerting some kind of control or boundary and saying, this is something I can do in the midst of a difficult situation. And of course, the calming and relief function is very, very common. So in most of the research, you will find to stop bad feelings or as a measure of self-punishment or to feel relaxed, this is the cluster of feelings that is most common. Now, why do we need to assess it? Um, of course, because first of all, to understand why these people will not find it easy to stop, because if it is serving all these functions for you, if it is making you feel calmer, if it's making it possible for you to cope with difficult situations, then really it's your crutch, it's your support, it's something that has a particular meaning for you, and it's really not a behavior that's going to be easy for the individual to stop. Also, as part of our assessment, as clinicians, to know that, you know, last week when the person injured, it might have been a particular motive, but a different motive can exist for each injuring act, or multiple motives can exist together. So it's really quite a complex act, and this is what we need to keep in mind while doing our assessment. So I'm going to share with you some very practical information, because, you know, in a clinical setting, it's not easy to remember all kinds of points like that. You know, let's say you're in a busy OPD or an inpatient setting or a clinic. So there are various questionnaires and interview schedules that really focus on things like the form, the frequency, the function, the context in which it happens. Are you injuring alone? Do you injure with other people? What is the impact it has on you? How does it influence your functioning? So one really good tool, which is an interview-based tool that I would suggest, is the NSSI 80. And this is put together by the Cornell group of researchers. I've also provided the website link. Excellent website, lots of resources, driven both by research and clinical expertise. So I think it's a really good place to begin with. Also, the next one is the ISAS, the Inventory of Statements about Self-Harm. This tool I would recommend if you're really looking at understanding the functions of self-injury, because it has excellent 22 statements that look at diverse reasons why a person may be self-injuring. And if you share it with the young person, they're really able to, because if you just ask them, sometimes they're not able to tell you all of them. But if you do a combination of a clinical interview and you use this part of the ISAS, you really get a good understanding of why the person is engaging in the self-harming behavior. So I think these are really good, useful resources, and I will urge anyone who's working more closely with this group to explore using, if not the whole thing, maybe selecting out parts that are most critical and working with it. Most of them are either free to use, or if you write to the author, they will just send you the questionnaire or the interview schedule. So I would really recommend that. The next thing is to assess risk factors and vulnerabilities, because one really knows working in you know, whether when you're a mental health practitioner. Okay, so I'll just continue. So when you're a mental health practitioner, I think we know that we mostly see patients with lots of comorbidities, lots of complex stories, many intersecting risk factors and vulnerabilities. And of course, with NSSI, it's no different. I'm going to just share some of the very consistent and key findings, not just from my own research, but also which aligns very closely with the international literature as well. And I'm trying to pick on those that are most important for us in our therapeutic work. Okay? So the first thing, no doubt about it, this I don't think anyone will disagree, that emotion dysregulation is a key vulnerability and sort of like a pathway to self-injuring behavior. No matter what research anyone does, I don't think I have come across any paper in which this was found to be not significantly differentiating the groups, or not as a you know, found to be a predictor or a pathway. I think this is important. But emotion dysregulation, it's a complex sort of phenomena. It's not just about not being able to manage emotions. It really starts with, are you able to identify or label your emotions? Do you accept emotions, or do you feel that emotions are just too messy, too complicated? They should be shut off or avoided in some manner. So is that the vulnerability? Is impulsivity a vulnerability? Or is it that when you're in a state of high distress, that at that point your functioning and your problem solving is impaired? So there are many, many dimensions to emotion dysregulation. And while we look at, so I will share a little later some tools that we can use to assess this. But I think this is one domain one has to dig quite deep, because not just the initial assessment part, this is going to be a key aspect of all the interventions we do with this group as well. So I put it right up front because it's absolutely critical. And we've also found that when impulsivity is an indicator there, this can really lead to fairly difficult outcomes for the young person. So we need to attend quite closely to that. Okay. The next domain that I think more and more recently we are understanding is that there's a developmental story. This young person has not started injuring just out of the blue, or we cannot dismiss it as, oh, it's just the teen brain, or, something like that. Typically in their developmental stories and histories, you will find a range of attachment vulnerabilities that are seen. Sometimes there are dysfunctional family backgrounds, sometimes there's parental psychopathology, or a history of bullying or peer related difficulties. And so you see a pattern of attachment vulnerabilities that this person is coming with. And this also makes sense when you see that a lot of the self-injuring may occur in interpersonal contexts in response to some perceived or real, and I think if it's perceived anyway, it's real, relational conflict or problem or difficulty. So I think the attachment vulnerabilities are another angle to look at. And so that as a clinician, we need to explore to some extent that as well. I've mentioned mentalization because this is a fairly recent focus area, but it is something that potentially can have a lot of implications for intervention. So I'm just throwing it in here that our ability to see our own minds from the outside and see the other person's mind kind of from the inside, and really understand some aspects of mental states that belong to us and to others. If in this area there is a vulnerability, so the whole understanding is that if social cognition or mentalization is impaired, this can really become a risk factor for non-suicidal self-injury as well. And in some recent research, we found that it was a partial mediator between attachment vulnerabilities and NSSI engagement. And I anticipate that this is going to be a prominent area of work in the next few years. Next, though, of course, we know that all people who engage in NSSI don't have a psychiatric disorder. That we know. But they have higher risk or levels or potential for mental health vulnerabilities of a different kind. So even if it's not a diagnosable disorder, they could have higher levels of internalizing or externalizing problems. But most commonly, it tends to be tilted, the research findings seem to be tilted more towards the internalizing spectrum. So anxiety, depression, stress related symptoms. And so that's something that we need to look out for. And other aspects are a tendency towards self-criticism and rumination, which go quite closely with the whole neurotic internalizing spectrum. So that's one domain that we need to keep in mind. Now, what does this mean? That all self-injurers are not going to be having these kind of vulnerabilities. There may be some subgroups that are more vulnerable. And so, for example, we often find a young person who says, oh, I just did it once. You know, maybe I saw something on social media, or my friend did it and said, you know, why don't you try this? And or I was with other people, they were all doing something, so even I, you know, poked myself in this way. It's clearly a transient experimental phenomena, which chances are not very high that the person is going to get into a repetitive pattern. But there are some subgroups of self-injurers who engage in multiple methods. They tend to pick the more severe methods to use. They are able to share many reasons why they injure and why self-injuring really helps them or meets some need for them. They also have an earlier age of onset. And what I haven't mentioned here is, but it's very important, is that they engage in it more frequently. So this is a group that, and if you see the proposed diagnostic category for DSM, which really didn't come through in the working group, was that people who injure more than 5 times in a year should be considered having an NSSI disorder, so to speak. But in any case, it tells us that frequency is a pretty important thing. So if there's someone engaging in multiple methods, more severe methods, telling you many more reasons why they self-injure and doing it quite frequently or repetitively, and report an earlier age of onset, immediately that's an indication for us that this is a more vulnerable group. And we've also seen in research that these are people likely to have higher levels of psychological distress and more difficulties with emotion regulation. So in our, now let's say we might be working in a clinical setting, in which case we're of course more likely to see the severe or problematic manifestations. But even for mental health practitioners who consult with educational institutions or other community organizations like this is one way that can help us sift through who are the self-injuring youth who need our attention more rapidly, and are likely to be the high risk profile that deserve at least some immediate care and attention. So once again, I think it's important to be practical. So I don't want to just leave it up in the air like that. I'd really like to suggest some tools and measures. We may not choose always to administer these measures to our patients, but or clients, but we may go through them and at least use some of the questions in our assessment phase or our interviewing phase. So one is the difficulties in emotion regulation scale. I would actually recommend that if you're working with someone in therapy and really targeting the self-injuring behavior, this would be an excellent scale to actually use. Because I found that young people are able to quite quickly fill it in, and then you're able to use it to give them feedback that out of the 5 or 6 domains that are covered of emotion dysregulation in the scale, which are the areas in which they seem to have more difficulty and which are the areas where maybe things are not that difficult. So it gives us a focus. It's something that you can then sort of connect with and say that this is what we're going to work on. The attachment style questionnaire, I wouldn't really recommend that it's routinely used in assessment, but definitely it's something that can guide us in the type of questions we ask, that how do people, how does the young person relate to others? Is there frantic seeking for closeness? Or on the other hand, is there a sense of, relationships are not important, they're too difficult, let me protect myself, let me avoid and stay away, isolated from people. So you can get an understanding whether there is some dominant style of relating to others, which you need to keep in mind. Of course, is going to then enter into your therapy relationship as well. So it's a good idea to at least have some understanding of the attachment style. And of course, those with higher risk profiles, it would be recommended to assess for affective disorders and other comorbid conditions for them as well, so that if that requires some intervention, we can plan it. So I'll get to this issue of self-injury and suicide. It's what do we do? We really need to assess suicide, because when you look at NSSI literature, there's been huge amount of effort to really separate NSSI from suicide and say it's something different. It's not to be confused with suicide, and we really need to look at it and even study it separately. But of course, the relationship is complicated. In one way, some people will say that I engage in NSSI because it protects me from a suicide attempt. It is something that I do to release my distress, and therefore I don't act on any kind of suicidal feelings that I might be having. There are some people who report very clearly this is not suicide. This is something different. I do it for completely different purposes. And so they sort of separate the two. However, when you see, of course, if someone has engaged in NSSI, that person tends to be at higher risk for, later in the years, having suicidal intent or attempts. And that's something we need to keep in mind. It is a risk factor for suicide. We don't find it listed in many textbooks, because I think at that time the understanding was only to look at past suicide attempts. But I anticipate that past NSSI is going to be one of the things that we need to consider as a potential additional vulnerability for a suicidal act later. And so Joiner's theory is actually quite useful. So Joiner's theory of what makes a person engage in a suicide act. And one of the factors, apart from a feeling of not feeling like you're belonging and other risk factors, is also that once you engage in acts that make you little desensitized to pain, okay, or take away the barrier of engaging in something that harms or hurts you, it brings you closer to suicide. Okay? So NSSI definitely is something that can function in that way of reducing the barrier of making you desensitized to pain, or so it is something that is connected with suicide. In some of our research, what we found is that even people who report NSSI, let's say less than 20% of them would say that, at some point we've also had suicidal intent. At the same time, they're clearly able to discriminate that non-suicidal self-injury is something else, and this kind of expression is something else. So then who are these people? Typically those who are using higher number of methods, more moderate severe methods, have a more planned sort of approach to self-harm, higher likelihood of concurrent substance abuse, and of course female and higher levels of internalizing symptoms, which anyway is a risk factor for suicide, right? So these are the people who are likely to be more at risk for having some suicidal intent. Okay, so anyway, we cannot engage in these kind of predictive equations, right, when we are seeing people in the clinic. So I would recommend that we always keep in mind that though we are seeing someone with NSSI, there's always the possibility that there could be associated suicidal intent or a chance for it in the future. So it's something we always assess and look at. And one of the tools I would recommend, again, this is available, I think, on the Cornell website. It's a comprehensive interview that actually examines both the suicidal intent and attempt and NSSI. So if you're assessing someone and you feel like this person really, I need to inquire into these aspects as well, this is a good comprehensive interview. Of course, apart from what we would all typically do as clinicians anyway. Okay. Now I'll just go on to the area of interventions. As you can see, it looks like we've already spent a lot of time on assessments and how we need to do a comprehensive or individualized assessment. So I'm assuming we already have a good profile of the person's self-injuring acts, why, when, how, all of those different aspects are in place. Any associated risk factors or vulnerabilities are also assessed, and we have done this groundwork. Now, what do we do in terms of intervention? I think I want to spend a little bit of time, because maybe this is what I'm sure many of you who have worked with this group will share this view, that creating an empathic and sensitive space is really the key. You know, if they're going to feel judged, and if they're going to feel that they've been given advice, or maybe we're making them try to sign some contract, stop self-injury kind of contract right at the outset, uh, these are things that can then become barriers in the relationship, and can make our intervention work quite difficult. So in this field, one of the terminologies that's been used, which I find quite interesting, is called the idea of respectful curiosity. Okay? So you engage with the person wanting to know more about their journey of self-injury, when it began, um, what happens, how does it help you. So you're open, pretty much like what we do in the field of addictions, right? That we are ready to ask about how the person feels other so-called benefits of um, using that addictive substance, and what are the negatives in their lives because of that. So I think some sort of approach like that is recommended with NSSI, because it's also to some extent, one lens is that it's an addictive behavior of sorts. So we'll find that many of the approaches from the addiction literature have also been used here. I think reflecting on our own emotional responses is also important. In some of the initial work when I did with young people, and I felt I was pouring a lot of effort into proposing various strategies for them to stop injuring, to help themselves in difficult situations, but it wasn't really working the way I wanted. And I could feel frustration. Sometimes you get, really blocked and helpless when you're working with this group. So constant reflection on your own emotional responses is really very, very important, I think, when working with this group. And if you have other colleagues who are also there who you can share with and discuss, I think that's quite powerful as well. And why I'm saying this is because in my experience, it's rarely a very quick process of stopping self-injuring behavior, because they're typically quite ambivalent. The way they define recovery also might be quite different. So in some interesting research we did recently, when we spoke to a lot of young people who were, either seeking inpatient or outpatient care, and asked them, what does recovery mean to them? Do they want to stop? And if they said, or we didn't actually ask them, do you want to stop? We said, what does recovery from self-injury mean to you? What is your understanding? And what we found is that for many people, recovery and stopping injury was not the same. Okay, some of them felt that cutting it down is a good enough goal. For some, what they felt is that if I do it, less than so many times in a year, then I'm okay. For many, they felt that, I have many other difficulties in my life, and I don't want the focus only to be on stopping self-injury. A lot of them reported that they wanted to feel a sense of control. They wanted to feel that they had better self-esteem, or that some of the interpersonal and other difficulties also got attended to. So what they seem to be looking at is sort of broader and more in-depth and a very personalized kind of view. And each person seemed to have a different definition of recovery. So this really made us realize that if we don't spend time understanding what do they really want to do, what is their understanding of recovery, then we're going to get stuck. We'll just be paralyzed and not be able to move forward in our therapy as well. So again, what's we found helpful is to again borrow from the addiction literature, assess the stage of change they're at. So are they in the pre-contemplation stage and the contemplation stage? So, use that kind of framework. And motivational interviewing techniques are quite, again, good at the outset to really start the process going, to understand that are they ready to make a slight shift, and even to shift them from one stage to the other is perhaps an important part of the journey. And we should not always be focused as clinicians, on my only goal is to get them to stop. Okay, because that can be then a lot of pressure and not really sort of connect with what that person's experience is. So what their journey of self-injury has been, what their idea about recovery is, unless we engage closely with that, I think it would be quite a push and pull kind of situation all the time. So really, as clinicians, important to be very patient in this process. Okay? Now, what are the interventions? We all want to feel we have a toolkit, we know what to do. So I'm going to at least share some of the things that are useful in working with this group. Like I said, and I'm saying it many times, but I think it's really important that we need to have individualized treatment planning. Having said that, emotion regulation is pretty much with almost all young people who are injuring a very key target. And I don't think anything has really been separately developed for NSSI, but quite often the DBT skills module is the one that is adapted for working with this group. I'll just share some of the details of these things that I'm going to speak about. But before that, there's a lot of emphasis also on self-care, okay? Because this is a self-damaging act, or very often it's a self-punishing sort of act. So which is why your intervention approach also has to look at self-care, healthy and unhealthy activities. So it may not only just be, let's say, cutting or burning that the person is engaging in. Maybe the person is doing unhealthy eating, excessive use of social media, or maybe risky driving, or substance use in a way that is unhealthy, or other damaging activities which are not maybe damaging the skin, but they are part of that whole unhealthy, damaging, injuring self sort of dynamic. So that's something to really ensure, and that means it's a more holistic sort of perspective that we're using. And I'll just quickly go over, because obviously we don't have the time to dig into each of these DBT aspects, which really, I'm sure you might have some other program that looks at that as well. But the different perspectives, the different modules of DBT are things that we use. So one is the mindfulness module, where the idea is for the person to be able to take sort of a little bit of perspective, to let go of difficult emotions and situations. So a number of different activities may be used. Some of them are mindfulness meditation activities. Some of them are visual activities that you might use, that you imagine placing your difficult emotion or whatever it might be on a leaf that is floating down a stream. You're standing at the bank and you're just watching it go. So these are some of the different approaches one may use in mindfulness. A key aspect is, of course, emotion regulation. And it's quite a challenge initially to even work with emotion regulation at the step of identifying and labeling emotions. So I remember talking to one of my patients who said, I'm angry all the time. It was very difficult for her to really separate out times when she's not angry, or to understand that, even within anger, there can be different intensities, or the outward emotion may be anger, but maybe, there are hidden emotions. So this is just an iceberg, and there are a lot of other hidden emotions behind that anger. And how do you label and identify all your emotions? So I think it's really like the emotional alphabet that you have to enter with at the beginning. The other thing is for young people who feel that emotions are too messy. So let me just not get into it. Let me avoid them. They're dangerous, messy, and problematic, and I'm just going to sort of block them out in some way. And this is the concept of experiential avoidance. So emotion regulation doesn't mean hiding and protecting yourself from emotions. And while we may know that, for a young person, they may really think, let me just hibernate, let me just sort of block it, let me wear a protective suit and not let emotions impact me at all. But that perspective is one that we need to challenge and ensure that there's no avoidance of emotions themselves, and really discuss what the value of emotions is. in situations that are difficult, we help them do a reality check between what they're thinking and what some of the realities of the situation may be. And sometimes, even though that emotion, so suppose I'm feeling very, very upset and I feel that, it's no point being with anybody and I'm always going to be rejected. So I'm just going to isolate myself and never talk to, at least right now, not talk to anyone at all. Or I've joined a new college, I'm not going to speak to anybody. So the idea and emotion, and then of course that increases the distress. So the idea would be to help the person do a reality check and to see whether, even though the emotion is guiding you towards a particular action, can you do the opposite action and see what that means for you. So guiding then through different emotion regulation activities. And of course, distress tolerance is a very key aspect, apart from just a sort of rational acceptance of some of the difficult situations and the distress, also some kind of meaningful distraction and a range of self-soothing activities are also part of the distress tolerance component. And this is something typically we might enter with this, because if the person is meeting you with lots of distress, jumping into mindfulness may not be the best way to begin. Really helping them feel that the distress can be contained and it can be brought down to a level that is manageable, then we can enter into different things. And then of course, interpersonal effectiveness, helping them look at interpersonal situations that are challenging and how to build skills for that. So it's something that takes time to work with, and this involves a lot of work. So which is why that initial phase of engaging the person, making sure that they're shifting to a stage of change where they're ready to work with you is very, very important. Because if the person is saying, I don't even want to stop self-injuring, they're not going to engage with you in these sort of activities. So it calls for a lot of patience, I think, on our part to sort of gently lead the person to a point where they're ready to work with these interventions. I think given all the assessments and the research that we've seen, we do know now that if we use a developmental and interpersonal lens, we often find stories of family dysfunction, experiences of abuse and trauma, or disturbed attachment, at least among some, at least subgroup of self-injurers may present with all of this. So if we find that that's the case, then it may require trauma-focused interventions where needed. In our country, I think it's rare that somebody comes alone to see you. There's usually somebody or the other, often family. And so we have a lot of scope. I think this is huge strength for us, that there's a lot of scope for family-based interventions and work. And I think that really needs to be, in India at least, something that we keep in mind and don't work only with the individual when there are requirements to work with the family and relationships. And all the findings related to disturbed attachment really tells us that the key focus needs to be on the therapeutic alliance. That's where if the person has relational sensitivities, then we need to strengthen that, so that can be a secure base from where they can explore and work with different ways of dealing with their distress. And finally, of course, to treat any comorbid mental health vulnerabilities that are there. Much as we would like it, it's not usually the case that if you treat any comorbid mental health vulnerabilities, the self-injuring just stops. Often that has its own pathways, and we need to work with that as well. Okay? So I'm going to end here so that we have much more time for interaction and discussion. I don't know, I can see lots of lines and things on my screen. I don't know if it's visible to others as well. But in any case, please, apart from the discussions today, I'd be really happy if anyone would like to reach out via email or look for any of the work that's available on ResearchGate. Please connect, because as I said, it's a very important area for me, and I'd be really happy to learn and share with all of you. Right? Thank you then.
Thank you so much, ma'am. We saw the cut on the screen. So I'd like to, Amrit, can we invite our chairperson for a brief comment? And
Yeah,
then
please,
we go for
please.
audience?
So I think that moderators should start with question answer. Then at the end we should give commentary. You can ask Professor Awasthi for his opinion.
Am I audible, sir?
Yes, sir.
Yeah. Well, first of all, before we open the forum for further questions and answers, I would like to congratulate on behalf of my co-chair, Dr. Om Prakash Singh, the excellent talk which has been delivered by Dr. Purnima Bhola. It has touched on the various aspects. We didn't expect you to make us suddenly wiser about how to, deal with this problem in young adolescents or early adult populations. But definitely, you have succeeded in imparting certain kind of sensibilities and being able to make us aware of the various issues which can be, there for us to recognize before we deal with such subjects. Generally, I'm speaking on behalf of psychiatrists, we have a tendency to rely on pharmacotherapy in our own notions that probably we can take care of these things, and we give much more importance to comorbidities, mental health comorbidities. I'm very happy that you have stressed more emphasis on mental health vulnerabilities, and not only at the individual level, but in the interpersonal context, and then to address those along with whatever else you want to do with your patient. But anyway, will come to those things at the end of, as Dr. Singh has suggested, little later. I think it's about time if Dr. Singh has something to say, otherwise we should ask the moderators. There are many comments which have come through, and if the some interaction with the speaker can take place. Dr. Singh, what do you think?
Let the interaction begin, sir.
Sure, great.
I think because a lot of interesting questions.
Absolutely, absolutely.
Purnima ma'am, what will happen if I don't look out for this NSSI, and how will it hamper my patient? It is a question according to my low IQ, so kindly allow me to ask.
So
what happens if I ignore this? What happens if I ignore this concept? If I ignore all these things going on, what harm are we going to have?
So, I mean, I can speak from different perspectives, clinical and from the research angle as well. I think that when I have seen people in their 20s or even 30s who are still self-injuring, they report a huge amount of distress over the years when their vulnerabilities have not been recognized. And I think it just then has a cascading effect. Am I audible?
Yeah, yeah.
Yes, ma'am, you are.
So I think then it has a cascading effect. Not only does it then give rise to more mental health vulnerabilities, it also impairs a lot of interpersonal relationships, their functioning either at work or in the educational spheres. So I think it really calls for, it's a kind of an indication of many vulnerabilities. So I think it's a very good signal for us, and which is why it's really important for us to pick it up. Also, from the point of view of research, those who have not received intervention and who have repetitively self-injured, they have much more problematic mental health and functioning outcomes. So I think it's absolutely critical for us to do this. And what we will find is, at least I found when I began, that as I asked, it was almost too much. There were so many people who were reporting that behavior. And so clearly it's a way that people deal with distress. And as mental health practitioners, that is our job, to understand and work with the different presentations of distress that people bring to us.
There is a question. Can repetitive NSSI be put under the obsessive spectrum, madam? And how to differentiate whether it is obsessive?
Right.
Because in both cases, they don't get any pleasure out of it. So how will you differentiate between both?
Actually, so I think that when it comes to obsessive conditions, there are certain very specific things, that is ego dystonic, it's, all of those characteristics are not all met by NSSI, because a lot of people will say it's intentional. It's not something that just pops into the mind unwarranted. It is something that they engage in because it has some meaning for them, serves some purpose for them. And while it may have a repetitive nature, I don't think it meets all the other criteria for an OC type of presentation. So at least it has been quite clearly differentiated from, obsessive compulsive manifestations. Of course, we could check because sometimes it can present like that. So like we would do, in our diagnostic approach in the beginning, but typically the two have not been assessed.
Actually, I want to add here, though classically it will not come under SSI, the serious disorder in male, we have to rule out, particularly if they have serious, severe self-injurious behavior. And their OCD is also comorbid kind of thing. So Tourette disorder has to be looked into if it is very severe and it is male. So classically it does not fit in the concept, but clinically it is the same.
Continuing with what Dr. OP sir has told, I see a lot of male, NSSIs who have been sexually abused in the childhood. We always associated a lot of females with NSSI with child sexual abuse, but now I see a lot of males who are coming out, and then when you because they generally they're too ashamed to talk about CSA. The males are much more ashamed than the females. So somewhere I see a lot of association with NSSI with CSA. Can you please elaborate on that, madam? There are some questions on that also.
I think that's an excellent and very sensitive sort of question that you asked, because I think that both for men and women, as we know, even in the government-funded research survey in India, that CSA is prevalent among both men and women, boys and girls, both. And I think it's a common risk factor. So I think it's a sensitive clinician who will keep it in mind.
Moderators, can we help the quality of sound of Dr. Purnima? Her voice sound is cracking, so can we help it?
Pavan, can you help? Madam's voice
Ma'am,
is...
can you keep the, if you are using hands-free, can you keep it close to you? Or you are using directly laptop?
I just increased the sound. Directly laptop, yeah. I don't know whether it's because the internet connection sometimes is a bit patchy.
Yeah, that's
And then you can switch off the video.
Let me do that.
Maybe the voice quality goes.
Yes, bandwidth will help in that case.
Again, yeah. So what I was saying is that abuse is a very common thing that extends across both genders. So I think for a sensitive clinician to ask it's about this issue, because I think SSI developmental history recognized as problematic. So there's family dysfunction, there's abuse, trauma of different kinds, not just sexual abuse, but often appear.
Ma'am, it's not helping.
Not helping?
No, ma'am, it's not working. It's still disturbed.
Maybe changing position at your place.
Okay, let's move and see whether it gets better.
I think somebody has his...
I've just shifted position. I don't know whether this makes it better.
Pavan, will you mute all the rest of the people except the moderators and the
yes,
speaker?
sir. Everybody is mute, sir, except the moderator and speaker.
Shall I try once again? Is this better?
No, madam. No, madam.
Shall I try to use my mobile hotspot and see if that works?
Relogging will help. Relogging will help.
I think the rest of the group can continue with their own contributions. So Dr. Amritpal Joshi had asked a very interesting, made a very interesting observation with regard to the childhood sexual abuse and those kind of, I think we should include bullying also along with it, which sometimes we go through, our children go through, and that can also have some contributing role. Others can join in, I think. What do you say, Dr. Singh? We allow others to join in now till Dr. Purnima Bola is back with us. Yeah.
I have a question for the esteemed chairpersons. Can we consider it as a type of impulsivity?
Okay. If Dr. Singh permits me, I can come now to, because that will fill the time, save us the time till Dr. Purnima joins us. Well, as far as my understanding is concerned, it is how you define an SSI that will probably tell you what kind of the population that you are catering to. If you are only going by some kind of a damage or an injury on your body, then it restricts your definition, and but it opens up a lot of possibilities which are diagnostic in terms of clinical diagnosis or even otherwise also. Yes, it could be a part of the impulse control disorder. It could be a part of the OC spectrum also. It could be because of neither of the two, but maybe because of the personality dimensions, which we have to keep in mind, like borderline personality. Just to give one example, we think of the mental health vulnerabilities. It can be low frustration tolerance. It can be seeking attention. It can be having some kind of an anchor, and where the therapist provides a lot of support. So in your own total therapy, and in your first year assessment, you have to see what you have to address, as I have learned over a period of time, because it's a heterogeneous condition. Once you have sorted it out, I think there are certain general principles which you need to keep in mind. Not almost all of us cannot claim to be experts or well trained in dealing with these people. Nevertheless, we all have some idea of how to use the principles of a supportive psychotherapeutic intervention and a re-educative psychotherapeutic intervention. Combine the elements of the two and keep some contact with the patient. The main thing is anchoring of the patient, which you can, if you can ensure it, that helps to take the patient along with you or the client along with you and makes him or her navigate the journey of life. It's a long-term engagement. Nevertheless, I think I'm very glad we can again see Dr. Purnima. So we should, I think, give her the opportunity to answer. Dr. Purnima, the question was whether it could be an impulse control disorder, a part of it or a variant of it. That was the question.
Actually, Dr. Awasthi, I heard what you said, and I think you covered it all really well. So I don't want to add any more to this question. I think, thank you.
Well, Purnima, I had another simple question. As you are here and others are there, I shall finish very simple. Are there any endorphin abnormalities in this NSSI repetitive NSI?
Sorry, I didn't catch that.
Endorphin receptor abnormality.
Endorphin.
Well, actually, there are hypotheses about pain sensitivity related to endorphins, but largely what I find is that it's restricted to research studies and it is not really translated into any kind of meaningful use in the clinical setting. But definitely there's a lot of research particularly the pain sensitivity and the role of pain. How come they are not experiencing high degrees of pain despite
Right. That is the assumption.
Yeah, even serotonergic, lot of research and the serotonergic pathways and those things is available, but clinically where it leads you to, that is, I think, the scope of another presentation. At this time, largely let us focus on how to engage patients and how to help them out of it through these psychotherapeutic maneuvers. Yeah.
And the role of social media, people do these cuts and they post and they share. Sometimes it becomes sort of a cult sort of thing, group of people doing that. We also had this blue whale challenge sort of things going on. So your take on this spectrum?
Yes, so actually there's a lot of work now on social media and its role. One is that of course in the damaging way that you mentioned, that people will engage in self-injury and then they will post the photos and it's potentially triggering for other people who then engage in that behavior together. Earlier, I think before the advent of internet in this way, there would be groups of people who do it, together. They're almost like self-injuring groups, and a lot of them will belong to what should I say? They align with the Japanese emo subculture, etc. So I think there was a lot of that happening. However, I feel that social media has a positive role also to play. Because there are a number of chat groups and other support groups to support those who are self-injuring in their journey of recovery. So those are some positive aspects as well. I feel like we need to maybe keep all of those aspects in mind. I think I've also become a little bit more sensitive to this issue. So when I have someone who's self-injuring, I do ask them about their social media activity. Sometimes I've found those with attachment related difficulties, if they've not got the required number of likes or responses to some of their posts, sometimes that can be a trigger for self-injuring. So I think social media can play a lot of complex roles for young people. And this is perhaps something we need to include in our assessment as well.
Is there any role of culture in NSSI? Because there are lots of culture.
Vivek sir, you have gone on mute. Please unmute yourself and complete the question.
Hello.
Yes, sir.
There are lots of cultures where self-punishment is glorified.
Yes.
So, is there any role of culture in NSSI?
Yes. So on one hand, the definition of NSSI, of course, excludes cultural practices, but that is a different aspect, right? So self-flagellation or, other forms of, let's say walking on coals or those kind of things as part of religious rituals. Now that's part of it. But I think what you're really asking is that certain cultures like the Japanese culture or other shame-related cultures where injuring yourself as a way of punishing yourself for some action that you have done or not done, or expressing in this way seems to be either glorified or acceptable or encouraged. And I think although we don't have specific research related to NSSI, I think there's research related to suicide, and perhaps some of those things may translate in a similar way to NSSI as well. Like we see even in terms of suicide, why do certain states or parts of the country have higher rates? So I think those cultural perspectives really do need to be built in. And of course, I think the youth subculture is a culture on its own. What they believe is a way of expressing distress or a acceptable way of expressing emotion. So I think that's another part of culture to keep in mind. But I agree that it's an important, very important aspect.
Alim, there are two questions on DBT, madam. DBT is widely used intervention for individuals with self-injurious behavior. In DBT training, mindfulness, emotion regulation, distress tolerance, interpersonal skills are used. The question is there any particular order like mindfulness, then emotion regulation, and in which skill training done? And what's the difference between DBT-A, DBT-M, and classical DBT? The two questions, set of questions regarding DBT.
So, what I would say is that if you read the literature when it comes to DBT and NSSI, there is no clear indication of which route you have to take, which pathway you have to take, where you begin. But I can say from my clinical experience, typically I would start with distress tolerance, with most clients, of course. You start with distress tolerance that gives them a feeling that the heightened distress can be manageable in some way. Quickly incorporate some emotion regulation strategies. And then I don't think I have any specific order of one or the other, because sometimes for some young people, all the mindfulness strategies don't always connect with them. For some, it's very effective. Some feel it's not for them. So that one would pick and choose depending on. So I think in the literature, there is barely any research which is looking at interventions in particular, and especially with these different variants of DBT and NSSI, I really have not found anything. I'm going to just predict something that in the next few years, I think we will see an upsurge of interventions related to mentalization. Because I think that is a very integrative therapy. It is one that is very rooted in social cognition type of research and neuroscience research. It has very clear skills and things that can be translated into working with NSSI. So I think I would see an amalgamation of the typical DBT approach and the mentalization framework as a possible, a stronger intervention for NSSI in the next few years. I don't know, I might be wrong. I might be like one of those astrologers who makes wrong predictions, but I'm just trying it based on my reading.
Yeah, ma'am. people have asked, some people do this NSSI to make others feel guilty or seek attention. And another related question, isn't NSSI also a cry for help?
Yes. Okay, so both, I think, excellent questions, which are really at the crux of what is NSSI and why do people do it. I think while we can use the word to get attention, I think we have to be careful that we don't see it as a frantic attention seeking or manipulative kind of act. You know, of course, it draws people's attention to you, but perhaps in the same way that a cry for help alerts people to your distress. Okay? So I would prefer that we keep a little bit of balance between understanding the need for attention, but not labeling the person as attention grabbing or manipulative, which is sometimes a label that is stuck on them and their actual distress is not sort of understood appropriately by even by us as clinicians sometimes. So I would clearly say it is a cry for help. At the same time, there are young people who will work very hard to make sure that nobody knows that they are self-injuring. So there's that group as well. They don't want to. I had a young girl who would always wear long sleeve t-shirts because she used to cut her forearms and she didn't want anyone to know. So I think that little bit of distinction needs to be kept in mind. Sometimes it's a very private act. It's nothing to do with wanting anyone's gaze or help directly.
And how to do the risk assessment if someone is having an SSI? So I might be repetitive. You tell me in a very simple words how do we assess the risk?
Okay, so the way that you would assess risk is by perhaps first starting with the NSSI behavior itself, because that's what they're presenting with. So you look at whether they're using more severe behaviors such as cutting as opposed to slightly more minor behaviors. You would look at, so those who are using more severe behaviors, automatically they get some more points in the risk assessment. Those who are doing it much more frequently, so if you're looking at someone doing it repetitively, someone who started quite early, uh, uh, and someone who reports that it meets many needs of mine. I do this to feel some relief. I do this for this purpose, that purpose, and they list many different reasons. And you know that it's a very important behavior for them. They're not going to let go of it. So that person is automatically at higher risk. At the same time, we will assess for any mental health related vulnerabilities. Someone with any additional mental health vulnerabilities, of course, higher at risk. If they have other risk indicators like trauma, etc., which again have complicated outcomes and difficult processes, that again would be an additional thing. And of course, the most important risk that we always need to keep in mind is that is there any associated suicidal thoughts, intent, the way we would assess suicide risk.
Dr. Purnima, can we just keep the answers a bit short, you know? Sure, please. I think we have, this is a question to the chairman and the moderators. We are past 9:30 now. So for how long we wish to continue and in what format, you are the people to decide. As chairpersons, it's our duty to inform you that we are past the time allotted for this program.
We'll take 2 more questions, sir. If that's fair enough.
You're most welcome. Go ahead,
what is
but then you decide when to finish it, okay? Yeah.
No, sir, it's just the last question maybe. What is the role of psychodynamic psychotherapy in prevention of NSSI?
Though I think I have come across one research study that has looked at transference focused psychotherapy with NSSI. This is not something that is used very often. I would say some principles from psychodynamic therapy as related to transference, counter-transference, the therapeutic relationship, those may have some meaning, but on the whole, I don't think this is a prominent intervention approach.
Ma'am, I have, suppose I have just 2 or 3 minutes to talk to the patient. So what maximum information or what maximum intervention can I do? It is not possible to do in a few minutes. I am in a busy OPD. Some snippets that I can tell the patient in 2 or 3 minutes. so that in addition to my regular advice, I say this and the patient is helped at least to some extent.
So I would
from a
say,
busy person
yes.
perspective, yeah.
So given the fact that it's a busy OPD, I would say keep a focus on emotion regulation, some basic strategies from DBT, such as distress tolerance and some of the simpler emotion regulation approaches. I think that at least would be a beginning. And for someone to try and use that and come back to you. With some patients, I've also shared some resources with them that they can work with later. But of course, since this is not something we can do so rapidly, so the therapeutic alliance is really critical. Nevertheless, something is better than not addressing the issue at all. So if they feel that you're interested, engaged, you want to work with them on this, they're likely to come back for some additional work.
Thank you, madam. It had been wonderful. I think, Alim, we should close. So over to our state president is waiting, Dr. Surjit Sahu and Dr. Rajnikant Shukla.
Any comments from the chairperson?
Chairperson,
yeah,
I just wanted to add one that I can see some very interesting questions that I have not been able to address. So I would
please address them.
Have a thing of the chat that I could go through later. And
I'll make it available to you, ma'am.
We can continue, madam, if you want, sir. If she wants to take the questions.
If you can allow, Purnima ma'am, you can take a few minutes and explain the important questions that you have.
No.
Chairperson should be lenient in that.
It's okay, I don't mind. I think we are quite out of time. So if somebody get in touch with me later, I'm happy to address them otherwise, because I think most of the questions are quite in-depth.
So we'll share the questions with you and we'll look forward to another session. Now, please, moderators, hand over to the chairpersons.
Sir.
Chairperson, sir, please take over.
Before I go to sir, I must say that this has been a wonderful session. I must thank the speaker for really enlightening presentation, and also our moderators, Alim and Amrit, for moderating the session and taking the questions. A lot of people have very interesting questions. And one of the question was like whether it is cult. I think that should be discussed, because it's just not a study, but practically tattooing, though it is excluded, there are competition who can have larger tattoos and tolerate more pain. So perhaps maybe it's something maybe related to this also. With this, I hand over to Professor Awasthi for his final comments.
Well, very short comments to say. Am I audible?
Yes.
Very short comments. 3 things I have learned today, this evening. First, that this is an important area in the clinical practice. 2, we deal with heterogeneous population. And 3, the key is to keep the patient engaged with you. If we can do that, we can succeed in some number of patients at least, There are many intricacies, many complexities of this issue. I think it's very generous on the part of Dr. Purnima Bola to solicit all the comments, and you can have a chat with us later, those who are interested. And then towards the end, I would say that it's an excellent platform. God bless my dear friend Tufan Pati and my 2 very young, dynamic friends who are like my younger brothers, Dr. Alim Siddiqui and Dr. Amrit Patjoshi, to continue with this effort and with this endeavor in these difficult times. I really enjoyed my time today. Dr. Om Singh, great to have you with us. And I can see that Dr. Gautam Saha had a good nap. Dr. Aseem Malik also had a good nap. And I also see Dr. Parmar. So Dr. Shashi Rai, I see she has been all through with us, and it's fine. It's looking at all of my fraternity. Dr. Batwe has now appeared again. So good luck and stay healthy, stay safe. Thank you.
Thank you, Dr. Awasthi. Thank you.
There are a few seniors with us. If they want to make any comments, we'll take those comments first, and then we'll hand it over to our state president, Dr. Surjit sir, who is waiting. Sir, Gautam sir, Any comments?
Yeah, no, it's fantastic, and really congratulations to the speaker. It is an excellent session, and also the two chairperson, respected Dr. Ajit Abasti and my dear friend O.P. Singh, and definitely my thanks to Dr. Tufan Poti, you, Dr. Amrit, my dear brother, and Alim. Thank you so much for organizing such an excellent show.
Thank you, Gautam sir. Mishra
Dr.
sir?
Pinto is there. You
Thank
can
you,
ask
sir.
him for his comments. Amrit, Dr.
Dr.
Charles
Pinto?
Pinto is there. Charles
Dr. Pinto,
is-
sir?
Pinto sir is there. Dr. Charles Pinto.
Dr. Pinto, your opinion, please. Hello.
Request sir, unmute first, I think.
We'll move, sir.
I think he's not here.
Anybody else? Any people? Dr. Rai, Dr. Mishra, Dr.
Vatve,
Parma,
sir?
sir? Dr. Vatve, sir? Sorry.
Just to say that it was an excellent program. I congratulate the Bhola and both the chairperson and both the moderators along with Tufan Pati. Generally, these days when I'm working in a hospital, multi-speciality, when the patients are referred to as my physician, they say कि डॉक्टर बेटा कुछ नहीं है वो DSH है वो एक झपड़ा दे दो ठीक हो जाएगा. That's the attitude of the physician. So with today's lecture, I think I'll be able to explain them what is the difference between NSAI and suicidal attempt and comorbid psychiatric disorder. And we should make them seriously think about this quote unquote DSH because they are definitely criticized कि कुछ नहीं है DSH है उसको छोड़ देंगे भगा देंगे वगैरह वगैरह. So that's the attitude. What I have learned today is to make our physicians colleagues aware that this is the difference between NSAI, DSH, suicide attempt, and comorbid psychiatric disorders. So with all this, congratulations again. Thank you very much, Tufan. Thank you very much. ठीक है ना?
Shall we hand it over to us, sir?
Yeah.
Thank you so much. Sir, may I request our State President, Dr. Surjit Sahu, to give the concluding remarks and then, sir.
Hello.
Surjit, sir.
Hello, Amrit. I am audible?
Yes, you're audible.
Okay. Okay. Sir, namaskar. Good evening, everybody. On behalf of IPS Odisha State Bank, I just congratulate you all attending this thought demo session. And I am thankful to around 300 participants are there. And this is our fourth webinar, sharing the knowledge in the platform and from this eminent resource person, our different eminent personalities of the psychiatry branch and some psychotherapists also. So first I would like to thank the resource person Purnima Bhava for enlightening about that how psychiatrists can enter into more deeper aspects and how the physicians are ignoring this aspect. Then also psychotherapy practice is in this area, like already Bhatve sir was told that how it is being neglected aspect and how we can care for these patients and we can save lives. Then I must thank our IPS past president, Dr. Ajit Agasti, and honorary editor, Dr. O.P. Singh, for sharing his valuable time and to be with us in this evening. Then I must thank our mentor, Dr. Tufan Pati, as he stands always for every work of our society, and he is one of the very senior members serving more than 35 years in Indian Psychiatric Society and selflessness contribution to this society. Then I would also like to thank Amrit and Alim for contributing their time in this COVID situation, making it success. And I like to request Dr. R.K. Shukla, my elder brother, to give vote of thanks on behalf of our society. Thank you all. Dr. Shukla.
Unmute, sir.
Hello.
Yes, sir.
Good evening. Thank you. On behalf of the team Thursday Musings, I would like to thank our star speaker of today, Dr. Purnima Bhola, who gave a very excellent presentation on a very challenging topic, which is a difficult area for all of us, for therapists and psychiatrists. And a special note of thanks to the chairpersons today. They, if I may be allowed to use a cricket analogy, they were the right combination of Mr. Poole, Captain Poole, Dr. M.S. Dhoni, and the great English captain, Mike Brearley, in the form of Professor Ajit Awasthi, who rightly, at the right time, intervened astutely with his substitutions and with referrals to the third umpire. If I may be allowed to use the analogy of cricketing analogy. And a special note also for, like our president said, there were more than at a point of time we reached around 300 attendees. A special note of thanks for them, and especially to those who contributed with their suggestions and questions. And lastly, and not the least, our team members, Dr. Aleem Siddiqui, Dr. Amrit Parjoshi, and the brain behind all this, Dr. Tufan Pati. Thank you and good night.
Very well explained, Dr. Shukla.
Torrent also.
And we would also like to thank.
Lastly, our corporate partners, Torrent. I miss them, Torrent Pharma and Mr. Pawan Patel.
Thank you so much. So next week we will have extension of this. Pawan, can you just share our next, what is our next topic?
Next slide, please, sir. Next program.
आज गाना कौन सुनाएगा?
At least not
गाने के टाइम आएगा.
So we have Dr. Lakshmi Vijay Kumar in our next schedule. He has kindly consented.
So the topic will be assessment and management of suicidal persons. So there will be extension of non-suicidal behavior to suicidal behavior.
Fantastic. Super.
I hope everybody will join us. Thank you for your patience. Thank you for whatever minuses we had. Maybe we'll improve next time. Thank you all. Pawan, please stop screen sharing. We'd like to. Thank you, Purnima madam. We might call you again.